A 47-year-old woman complains of pain in the right leg. What do you see? Erosion, a soft tissue mass, cortically oriented. And then if you look at the rest of the bones, they're osteopenic. Look at the thin cortex, pencil line cortex, and almost no spongiosa. So some underlying osteopenia with a cortically oriented lesion. So what are the possibilities? Is it a bone tumor? No. Only it is a Ewing's, but the age is too old. And then there is no periosteal reaction at all. Osteopenia and this lesion, cortically oriented. What are the investigations do? Well, generally you may take another hand. Because of the suspicion of hyperparathyroidism and a brown tumor, you take radiology of the hand. And that typically shows, as the Radiology points out, subperiosteal resorption of bone, characteristic of hyperparathyroidism. We don't know whether it is primary or secondary. But if you look at the proximal phalanx of the index finger, there is a ballooned out lesion looking like a giant cell tumor. In fact, there are cases when patients presented with a mass attached to the bone or a bony lesion, a bony tumor, then when they took a biopsy, they called it a giant cell tumor. But then not investigating further, serum calcium, serum phosphorus, and other things, then we know it is part of a brown tumor, part of the picture of entire scenario of hyperparathyroidism. So we know now this is a case of hyperparathyroidism with a brown tumor in the middle third of the tibia. Brown tumors. This is another case. Looks like a fibrocortical defect or non-ossifying fibroma. These are healing brown tumors. After the removal of the parathyroid, that's how they heal. Eventually, they completely ossify and form a normal bone. Brown tumors, as we said earlier, they may be found in hyperparathyroidism of primary type or even secondary type in renal osteodystrophy. Bone resorption. What is a brown tumor? Bone resorption. Fibrous tissue replacement because of the resorbed bone. Cystic areas are seen, looking like a tumor. Hemorrhages, macrophages, and giant cells. That is the histological picture of a brown tumor. Whether primary or secondary doesn't matter. Then how do you investigate for parathyroid adenoma? All right, you said hyperparathyroidism. So it must be a parathyroid tumor. CT, ultrasound also may help. CT, color Doppler, MRI, but CT, as in this particular case, shows a lesion in the parathyroid on the right side. On your right side, I meant. Technetium thallium subtraction, it shows technetium, it shows all the thyroid and parathyroid, and then you subtract the thyroid from thallium and you find the parathyroid adenoma. Nowadays, cystoscopy also may be used. Primary parathyroidism, what are they? Adenoma, primary adenoma. Well, sometimes there may be more than one true adenoma. Hyperplasia, which may be mistaken for adenoma. Carcinoma of the parathyroid, part of MEA syndromes, multiple endocrinal adenomatosis syndromes. Or ectopic parathyroid hormone, for example, a tumor arising in the lung may produce ectopic parathyroid hormone. This patient, 50-year-old female with pain in the neck. A lateral view of the cervical spine is taken, but it may be passed as degenerative spondylitis, particularly at that age. But then if you look carefully, there is a soft tissue swelling, prevertebral soft tissue swelling, pushing the trachea forward. And not only that, if you look further, you count the cervical vertebrae. C5 is anteriorly eroded. With this, generally you think of tuberculosis, soft tissue mass, erosion. But then if you look at the intervertebral spaces, they are normal. There is no change. There is no inflammatory or infective change. There are no erosions. So what do you think of the lesion? Soft tissue swelling, lytic lesion. Well, it could be plasmacytoma, but soft tissue swelling is localized and it's too much. AP and lateral views, again they show the same thing. AP view, there is marked destruction, which On a lateral view, you couldn't see, although there is some wedging of that vertebra with anti-erosion, you could just pass it off. Soft tissue swelling is there. And then on CT, you could see a ballooned out lesion with calcifications, and this proved to be chordoma. From elements of notochord elements, the chordoma can arise. And then there are two types of chondroma. If there is extensive calcification, you could think of a chondroid type of chordoma, but they only constitute 20%. 50% of these chordomas may arise in the sacrum, 30% in the clivus. So in the spine, from one end and the other end, 80% of the lesions may occur. And then 50% in the rest of the spine, of course C2, C1, C3, C4, and also dorsal lumbar spine are the common sites. Age is between 50 and 70 years. That is important. Another case, to illustrate a backup case, look at the sacrum. Multiple rounded, arc-like, circular calcifications with a mass, which you could see on the lateral view, also multiple lump-like calcifications, chordoma, chondroid type of chordoma. 30-year-old male with history of right shoulder pain. And then plain films, there was not much except little osteoporosis, though, so they resorted to MRI. T2 weighted image showing erosions, synovial thickening. Look at that extension of the synovial thickening, which in plain films you couldn't really see. And fluid around bicipital tendon also. That grew, look at that fluid. So erosions, synovial thickening, and effusion. Differential diagnosis, again it may be rheumatoid arthritis because of the osteopenia shown in the plain films. T2 weighted image showing synovial thickening again, and most important thing here is axillary lymph nodes. I'm glad the MRI included the axilla. In rheumatoid arthritis also rarely you may get granuloma, but it's not common. So it must be tuberculous arthritis of the shoulder. Tuberculous arthritis of the shoulder, as you see, T2 non-star images, joint effusion with altered signal intensity involving humeral head and axillary lymph node. That's how the summary of the case is. Can you diagnose this by ultrasonography? Yes, probably yes, at least suspect. CT, well, CT doesn't show the nodes, and you can't really identify the effusion. The MRI clearly tells us what is synovial hypertrophy, what is bone erosion, and what is effusion, and in addition, axillary nodes. Young male, aged 37 years, had presented with backache and weakness in both lower limbs, and of course inability to walk. He presented in February 2004. Localized view of the thoracolumbar spine, mostly lower thoracic spine. You could see nicely lytic lesion and a slight compression of D10 vertebrae. So differential diagnosis goes from hemangioma to plasmacytoma to giant cell tumor. Of course not aneurysmal, so you can't think of an aneurysmal bone cyst. If it's an younger person, histiocytosis X. All these are the possibilities. Then CT is taken. You could see some occasional polka dot, but mostly cavernous spaces. So it is extending all the way to the transverse process also. Again, cone view of one D10 showing lytic area, large spaces extending into the rib and transverse process. And then they took technetium scan. Is it localized? Could it be metastasis? Or could it be multiple myeloma? Could be histiocytosis? So they took a bone scan, technetium bone scan, blood pool also. You see the interpretation, technetium 99, blood pool scan, immediate dynamic followed by serial static images up to 3 hours were acquired in posterior projection. Immediate dynamic images showed no abnormal tracer blush immediately. But blood pool phase imaging, sequential images revealed moderate increase in tracer pooling in D9 and D10 till 2 hours post-injection with no significant change at 3 and 4 hours with complete washout at 24 hours. So their interpretation is hemangioma. Then they took MRI. Again the same findings between T1 and T2. And so thinking that it is hemangioma, they did laminectomy on 16th February. D9 laminectomy, the excision of right pedicle with removal of lesion with transpedicular screw fixation and rod placement. By the way, it is not D10 but it is D9. Spicules admixed with sheets of plasma cells along with other chronic inflammatory infiltrates with areas of hemorrhage. That's why those spaces indicating of chronic osteomyelitis. Gross pathology, they thought it was chronic osteomyelitis. Histopathology section showed necrotic bone marrow indicated, said to rule out plasma cell dyscrasia. That's how the diagnosis comes. Plasmacytoma. Ultimately, the diagnosis was plasmacytoma. Well, in the differential diagnosis we mentioned hemangioma, plasmacytoma, metastasis, eosinophil granuloma, etc. Solitary plasmacytoma is an uncommon tumor. Age 5th and 7th decades. Location axial skeleton 25 to 60%. Thoracic and lumbar spine more common. And then pelvis. Ribs, sternum, skull and femur. Actually no bone is exempt. We have seen plasmacytoma in the humerus, tibia, etc. Radiologically it is only lytic expansile lesion and sometimes with a soft tissue swelling. Age is important in these cases. Review of the literature. MRI is significant, they say. On MRI, 10 patients have been studied. All had expansile lesions with low signal intensity on T1 and high signal intensity on T2 and involved the entire vertebral body. This is what they call it mini brain appearance in an expansile lesion of the vertebral body is sufficiently pathognomonic of solitary plasmacytoma. Look at this picture. Almost looks like a brain, mini brain. Now, next case is a 45-year-old man with chronic disorder of left hip, chronic pain. He has been complaining, going from hospital to hospital. These are the pain films. The neck is completely absorbed. Multiple cystic changes are noted, both in the acetabulum, extending the iliac bone, and in the trochanteric area and subtrochanteric area of the femur. Is it a neuropathic joint? But there is no new bone formation. There is no fragmentation. There is not much of a soft tissue swelling. So what is the diagnosis? Well, again, coming to the radionuclide scan, it is just cystic changes. No vascularity is noted. Diagnosis is hydatidosis. It's rare. It's not easy to diagnose unless you are familiar with hydatid disease or tropical disorders. Produced by larval stage of the dog tapeworm, liver, spleen, kidney, lung, brain, and others are common sites. Bones are less common. That's why you don't think of a hydatid disease. It is less than 1% statistically. Just this specimen to show it is a dog, from dog to humans, etc. Specimen. Next case. A 15-year-old boy complains of pain in the joints. So these are the AP views of both knees. There is duodenum valgum and osteoporosis, rachitic-like changes. Look at the physis. This is widened. And nothing else much on these films. On the closed view, magnified view of the patella, you see irregular fringing of the articular margins, multiple ossicles. That should give a clue. In fact, if you go back, there may be changes in the articular margin of the femur as well as the tibia, also similar changes, fringing, irregularity, maybe some ossicles. That should give you a diagnosis for Wilson's disease. What are the skeletal abnormalities? Subchondral cysts, which we don't see in this case, chondrocalcinosis, osteochondritis dissecans. Sometimes they may come with osteochondritis dissecans, and chondromalacia of the patella, the spine, Scheuermann's type of spine, premature degenerative joint disease, osteoporosis or osteomalacia and rickets, which we have seen here. So the findings here are fringing of the articular margins, irregularity. There's not much of osteochondritis or dissecans, but rickets is there. Of course, clinical findings, hepatological degeneration. Wilson disease or hepatological degeneration is a neurodegenerative disease of copper metabolism. In 1912, Wilson first described it as a familial disorder associated with neurological symptoms and cirrhosis of the liver. Wilson disease involves loss of ability to export copper from the liver into bile and to incorporate copper into hepatic celluloplasmin, that is the enzyme. Consequently, copper accumulates in the liver, brain, kidneys, cornea, and cartilages. Again, another example of Wilson's disease. Look at the styloid process ulna, fragmentation, multiple ossicles, and of course there is rickets. The physis is widened. And look at the radial surface of the articular margin or the epiphysis of the radius. There is again fringing and multiple ossicles. Classical of rickets plus fringing of the articular margin plus ossicles. Classical of Wilson's disease. Of course, clinically, Kaiser pressure rings are almost always present, particularly when the patient has neurological symptoms. Look at the ring around the brown ring around the cornea and the nail depigmentation. Skeletal abnormalities, to repeat, osteoporosis, osteomalacia, chondrocalcinosis, premature osteoarthritis, joint hypermobility. Of course, CT of the brain shows hypodensities in the putamen, extrapyramidal system, and cerebral atrophy. Occasionally, these people come with hematemesis because of the cirrhosis of the liver and esophageal varices. I have seen a few cases like that. 28-year-old man complains of chronic pain in the right buttock. In a radiology of the pelvis, what do you see? Sclerotic density in the right iliac bone. And it is superimposed over the sacroiliac joint too. The joint itself is normal compared, although we don't see much, all we see is haziness, but if you compare the space between the right and left sacroiliac joints, they look normal. The most important is irregular, homogeneous type of sclerosis. Again, same finding that you see the pelvis. On CT, it is an expansile lesion. No soft tissue mass at all, so you can't think of a malignant tumor. Irregular sclerosis in multiple lucent areas. Sacroiliac joint, upper part is slightly involved. This is chronic sclerosing osteomyelitis. Generally, osteomyelitis could be divided into acute, subacute, and chronic. This is chronic. But in chronic osteomyelitis, we generally diagnose in tubular bones if there is a sequestrum and surrounded by involucrum. Here, most of these, there may be small involucra or even sequestra, but most of it is superimposed, or most of it is because of the reactive bone that engulfs the small lucent areas. This rare lesion is secondary to Staphylococcus aureus generally. Common in long bones, but occasionally you can see in flat bones also. Histologically, there is no necrosis or a pus, purulent exudate, you don't see, because it is all absorbed into a granulomatous tissue and then reactive bone formation. Bone infections, what are the common complications? Chronicity, acute, subacute, and chronicity. Fracture may occur, pathological. Osteonecrosis may occur, particularly if the epiphysis is involved. Premature fusion of the epiphysis. Deformities, malignancy, and amyloidosis. Malignancy, particularly not only in the bone lesion, but also in the sinus tract. Squamous cell carcinoma has been reported. Osteogenic sarcoma has been reported. That is the tail of the entire filament petition. I emphasize on this point, conventional radiology is still best in diagnosing bone lesions. Thank you.